endocrine surgery at the University of Alabama. She is the vice chair of education and the assistant dean of the UAB Graduate Medical Education Office. She's the program director for the Endocrine Surgery Fellowship. She earned a master's of education in health professions from Johns Hopkins University and served as a member of the board of directors for the AMC for 4 years. She is an author of the AMC's core EPAs for entering residency, and she's published over 13 papers on EPAs in high impact journals, served as a consultant to various fellowship EPA writing groups, and championed the developments of EPAs for endocrine surgery fellowships. We are extremely excited and honored to have Dr. Lindeman here to talk to us about EPAs enhancing autonomy in residents and fellows. Thank you, Dr. Lindeman.
Oh, thank you so much, Dr. Chitani. Thank you to the SSAT for allowing me to be part of what I agree is really an all-star team among the co-panelists that I have here tonight. And I am so excited to be able to talk to you about a topic of how to empower you as trainees, or if there are faculty listening, how to help empower your trainees, your residents, your fellows, to be able to utilize EPAs to enhance autonomy. I often say that this is our not so hidden agenda for advancing this competency-based assessment framework. So let's kind of dive right in. These are my disclosures. You'll see that most of them relate to EPAs. I do some work with the American Board of Surgery. They do not pay me. It's all volunteer. And I'll put in a plug for another organization that's near and dear to my own heart, which is the Association of Academic Surgery. So if you're young in your career, please check that group out as well. Okay, well, you came here tonight and we have been throwing around the acronym EPA already. Despite this very pristine, beautiful scene, I think you hopefully have figured out that we are not talking about the environment or the Environmental Protection Agency, but instead we're talking about assessment. And because I have the real honor of the first talk, I wanted to make sure that we're all on the same page, at least as it relates to our operational definition of what an entrustable professional activity is. Firstly, that's a mouthful term. And then the concise definition is EPAs are essential tasks of a discipline that an individual can be trusted to perform independently in a given context. Okay, that's still a reasonably short definition, but it's a lot of words. And the way that I describe EPAs most commonly is that they are tasks or units of work of a physician in that discipline. A colleague from emergency medicine calls them everyday physician activities. And so I think importantly, when we put them all together, they're kind of this mass of critical elements that define a profession or specialty. And for education nerds like me, they really allow us to shift the focus of what we're evaluating or assessing from the competencies, which are things that people have, right? I might have medical knowledge or I have communication skills, or I hope that I do. And it shifts our focus away from these qualities of people to the work that we have to do to care for this patient in front of us. And I think most of us, that's how we think about how someone progresses through training, right? So this diagram is just a graphical representation of the 18 EPAs for general surgery. I don't have graphical representations for some of the more advanced, like fellowship level EPAs, but I do like to harken back and point out that, this kind of demonstrates that general surgery is a discipline of individuals who care for diseases of the skin and its contents. And so I like how it's sort of mapped out. And in thinking about, really focusing on the work that we do, what I usually say to people is that we really adopt a much more holistic view. If I am lining up across the operating table from a resident or a fellow, really what I'm thinking about is how much do I trust this person, right? If I weren't there, could I trust them to do the entirety of this operation or whatever task it is that, is set before us? And we do this all the time. Every single case, at least every day, And there often is this balance between sort of the supervision that a faculty member or an attending feels like they need to provide versus the autonomy that we are able to grant to a resident. So if we pretend that, this is like a surgeon like me and I'm scrubbing in, what I might be thinking is, well, I've never worked with this person before, so I'm not really sure what they're capable of, right? So my scale is going to be tipped much more with much more weight toward supervision, right? Because I need to figure out what their level of competence is before I'm going to allow them to, be able to move with independence on this patient that signed up to have surgery with me. Or, in a worst case scenario, maybe I've heard rumors about someone like, oh, I heard this person wasn't very good, right? And that's what I'm basing my judgment off of. That shouldn't happen. But I think most of us recognize that these types of things tend to percolate throughout programs. And this is not what we want to be basing our decisions upon when we're trying to navigate this balance between supervision and autonomy. So as I said before, we already do this, right? And so maybe on a really good day, I can let the resident start and I can just scrub in for the key portion of the case and allow a lot more weight on the resident autonomy side of that scale. The challenge for us is that at least prior to EPA implementation, we had not been documenting at all these decisions that we're making on a day-to-day basis. And we didn't have a shared mental model. So I'm an endocrine surgeon, right? So a thyroidectomy, what I believe is great performance of a thyroidectomy may be very different from my partner's acceptable performance of a thyroidectomy. We didn't have standardized descriptions of the behaviors that we were looking for as we say this person can be trusted or this person, needs a little bit more supervision. And so that I think is really the power of EPAs and where they come in. And I wanted to walk through a few specific examples and hopefully back it up with a little bit of early data about this paradigm. So the first is, I encourage you to reflect back to maybe some experiences recently, or if you've finished your training, maybe back to when you were in training, and there's this conversation that happens at the scrub sink, right? Like maybe I've not really worked with this person before, or maybe it's been a while since I've worked with this trainee. And so the conversation kind of goes like this. And I was like, oh, how many of these have you done? Right. And maybe I'm the resident and I'm like, oh, I've done 30 lap choles before. Like I feel pretty good about this. But let's be honest, it really probably didn't matter what number that I said, right? Because the attending is then like, oh, well, that's great, but I'll show you how I like to do it, which doesn't really help me out as the trainee at all, or at least doesn't allow me to push my skills to the edge of where I am developing what's called the zone of proximal development, right? That area where I can struggle safely. So instead, maybe I, as a resident, could utilize the EPA data that I've amassed already to switch that conversation. And maybe I can introduce from the start, well, Dr. X, I know we're going to do a lap chole today, and I've done 30 of these, but I've actually been at indirect supervision for my last 4 cases. I would really like to work on, finding the critical view of safety independently today. And then Dr. X is like, oh, okay, well, why don't you start and, we can swap if you're having difficulty. It's a way to sort of pull back the curtain and reveal to the faculty member you're working with how much you are capable of. I think there are early data from the EPA pilot that use of EPAs can actually increase autonomy. So you'll see the photos, Dr. Jake Greenberg, he was program director at the University of Wisconsin during the EPA pilot. He's now on faculty at Duke University. And I stole this slide from him. But these are 3 years worth of data in their case log reports. And I know that it's small, but I'm going to highlight for you You can see in each of these 3 years, the column is the program percentile in these defined categories of case log reports. And at the very bottom are teaching assistant cases. And so I'm going to highlight sequentially in the year before the EPA pilot, they were in the 77th percentile of teaching cases at the University of Wisconsin. In the first year of the pilot, they went up to the 91st percentile, second year of the pilot, the 94th percentile. So demonstrating that their trainees were capable of, practice readiness for some of these things, I think helped them push the needle. What he says is it helped them push the needle to encourage more faculty to let their residents serve as a teaching assistant. Our EPA study group published this paper sort of about the clinical competency committee and how they went about thinking through summative entrustment for EPAs. And I think this is something we've talked about comparatively less. So I wanted to walk through this kind of flow chart in the figure. So when we talk about EPAs, we think about the first half of this figure, right? Where there's an EPA microassessment, we've had an intraoperative phase gallbladder, and the faculty, the resident does their self-assessment, the faculty does their assessment, and then it just kind of goes into the ether. But then on the back end, there can be this whole clinical competency committee process where the CCC then looks at all of the microassessments that have been completed for that trainee, and they decide, well, we don't have enough information to make a decision, so no summative entrustment decision is made. Or, yeah, we have enough information, and we're going to make a summative entrustment decision. Maybe that summative entrustment decision for that PGY2 is for direct supervision. And then in this study, they weighted how confident they were in their decisions. And so what we found is that more data was better. So the arrow goes down that, confidence increased with an increasing mean number of EPA microassessments. And when we broke it down by EPA and phase, I know this diagram is a little bit overwhelming, but in all of the ones that had a statistically significant difference, just look at the bars. You'll see that the high confidence, they had at least 4 or more EPA assessments on average to be able to make that decision about. So we can see that CCCs can then utilize all these microassessments put together, feel very confident about saying like, yes, this person is at, X, Y, or Z level of entrustment. This person is ready for practice, or this person still needs, direct supervision. And then it helps to combat this phenomenon that I credit Dr. Kevin Shaw, who's the residency program director at Duke now, this phenomenon of CCC gossip, right? So the figures to the right show examples of comments from real end of rotation evaluations, like not applicable or keep up the good work, read more, needs more opportunities to continue improving skills. Like, okay, yes, those things are true. And then because those things are not granular or actionable, then that whole rumor mill tends to start. So instead, now we are able to fill this gap with the EPA dashboard that clinical competency committees can use. This is an example of what it looks like at the program level. This was taken from our program at UAB. But the important thing is these are the data from one specific resident. And so here in the red box, we see their data about their EPA microassessments. And so you can see, the very first one, procedures in trauma, they got one evaluation from one rater and their average entrustability was a 3. Whereas we see, if you look 5 rows down, I'm sorry, I didn't highlight that separately, intraoperative gallbladder disease, 11 evaluations from 6 different people, and their average entrustability is a 3.5. So we can feel pretty confident that if I'm going to do a gallbladder operation with this resident, I can pull back the reins and just kind of let them move independently unless they need help. It also helps the CCC, we see in the blue box, that it'll map back to the milestones as the EPAs and the milestones kind of talk together. But the point of my time with you tonight is to talk about how you can advocate for more autonomy for yourself, how we as program education leaders can help grant you more autonomy. And one of the things that people have talked about is thinking through something like an EPA permission slip, right? So here's a very official permission slip. And if we translate that into EPA language, maybe it looks something like this, where in abdominal wall hernia, pre and post-op phases, you're at practice ready. So that gets colored in green, and intra-op, you're at direct supervision. For trauma, which is the next to the last one, you're practice ready all the way across. For thyroid, you still require direct supervision in the OR perhaps, but you can sort of use this and say, these are the CCC decisions about my readiness, and use that to sort of help to negotiate the things that you can do on, any individual given case with that faculty member. And correspondingly, faculty can use that to kind of calibrate their expectations for what they can let you do during a case. I also wanted to talk for just a moment about bias in assessment, because I think there's pretty compelling evidence that that does affect individuals' decisions about how much autonomy that they are going to provide. These data also come from the University of Wisconsin, although I will tell you there are 3 additional studies to this, 2 using EPAs and 1 using another rating scale that was based in observable behaviors, but was not an EPA observation, that showed similar findings. And so what this graph shows, if you look, so the one at the left is the resident self-assessment, and the female residents are shown with the dashed line and the filled in dots. And so you can see that at every PGY level, which is shown on the x-axis, pretty much every PGY level, that female residents tended to rate themselves like one entrustment level lower than did the male residents. But in the graph to the right that shows the faculty assessment scores, there was no difference on the basis of gender, which is different than other types of workplace-based assessment studies that have been done, and similar findings to all of the other studies that have looked at this in an EPA context. My hypothesis is that having this based on directly observable behaviors lessens the possibility of bias. I don't know that we can say it eliminates it, and we've only been powered to study this on the basis of gender. But as we accumulate more national data, we are planning to investigate this on the basis of other important sociodemographic characteristics. So with that, I will end, and I thank you very much for the opportunity to spend time with you this evening. I look forward to questions.
Thank you so much, Dr. Lindeman. Great way to start off developing a shared mental model of EPAs. We're going to keep moving because we're very tight on time. I would encourage everyone to drop your questions in the chat, and we'll get to them at the end. Next up, Dr. Karen Brazel. I messed it up. Dr. Karen Brazel, thank you, is the Vice President of the American Board of Surgery, she's a professor of surgery in the Division of Trauma and Critical Care and Acute Care Surgery at Oregon Health Sciences University. She led the initial ABS general surgery EPA pilot from 2018 to 2020, and has since been heavily involved in the ABS EPA project as a senior volunteer consultant. She was a member of both the General Surgery EPA Scope Council and Advisory Council, and also served as a facilitator for the General Surgery EPA Writing Group. Dr. Brazel is going to talk to us about EPAs bringing flexibility to training in general surgery, and we're very grateful for her time today. Thank you, Dr. Brazel.
Thank you so much. It's really a pleasure to be able to talk to you, and thank you so much to Dr. Chaitani and the SSAT for the invitation. I have a few objectives. I will talk about a little bit about flexibility, or kind of the new frontiers, but I think it's important to understand where we are currently before we can talk about what might be ahead. And in outlining what might be ahead, talk about the near future, and then talk about where we might or could go, understanding we have to have the information to be able to make informed decisions about where the future will lead us. I do think it's important to start with the why. And the why starts with the fact that we have a fixed time training model. And you can go all the way back to kindergarten, any educational system. When you have a fixed time model, you get variable outcomes. That is a fact. We have talented and gifted programs. We have programs for those who need a little more time to achieve the same outcome. And Thinking about this from the American Board of Surgery point of view, which has a mission to serve the public, it does not serve the public as well, or maybe at all, when we are certifying a product of a training program that has a variable outcome, despite the fact that we have protections in place and that outcome has a floor. So that's the first part of the why. The next part of the why comes from data that the program directors in internal medicine and anesthesia have maybe been braver than we have and published their actual data. Two different groups of program directors, actually in two different countries, one the United States and one program directors in Europe, asked the question of program directors, would you trust this person who you are signing off to take the next step to become accredited in the relevant specialties? Would you trust them to care for your family member? And a third of program directors in the previous 5 years had graduated at least one person that they would not trust to care for their family members. And when you get a group of general surgery program directors in a room with the door shut, no cameras, no microphones, sharing secrets as a recovering program director, that number, about a third, rings true. Which also, again, thinking about serving the public, this is a problem. We want to ensure that we provide the opportunities and the assessment tools to make sure that number is as close to zero as it can be. And as Dr. Lindeman already talked about, our current system without objective behaviors that we comment upon and rigorously assess is biased. So this is the timeline for the EPAs, and we are now well into the launch of EPAs for general surgery and are beginning the launch of EPAs for our other specialty boards. In 2028, those of you who will be applying for certification in 2028 and beyond will be required to submit a profile of EPAs in order to enter the certification process of the 2 certifying exams of the American Board of Surgery. Dr. Lindeman also gave you the 18 EPAs. What I would like to highlight on this slide is the vast number of resources that are available to programs, to residents, to faculty, that show how to optimally implement EPAs to guide your own autonomy, as Dr. Lindeman said, to help your faculty, to train your faculty. It's really a rich resource. And I think the number of people who have contributed to those resources really speaks to the understanding that we all have that our current system has some problems, and we are willing to volunteer our time to contribute to making resources available. This is one of them. This is the ABS app that's hosted by Simple. Hopefully, all of you have had a chance to use this or one of the other platforms. We invested in this app because one of the things we learned from the pilot was that we needed to make the assessments, collecting of the information, as easy as possible. We're actually agnostic to what platform the programs use. And there are 5 platforms that are currently in use, 3 that have the majority of use. And here are the data showing where we are in terms of assessments that have been collected. We get about 25,000 EPAs per month, and about half have been initiated by residents, and the other half have been initiated by faculty. So what have we found from all of these assessments? Again, there's about an equal number of faculty and resident assessments. there's a slight predominance of these assessments for PGY1 and PGY2 residents. However, it's only slightly predominantly PGY1 and PGY2, which again says that it is really two things that drive that observation. One, it is easier for faculty to learn how to do it for all residents rather than to try to remember, I have a PGY2 on my service this month. It was a PGY3 last month. I didn't really have to do it. I do have to do it now because I have a PGY2 instead of a PGY3. Anytime you try to change faculty behavior, it's a very difficult process. And so decreasing that cognitive load. And I think it speaks to the value that many residents have found in the EPAs. As you might expect, the intraoperative phase of care has the vast majority of assessments, about 80%. And so that leaves 20% that are evaluation and management, whether that's pre-op, post-op, or the consult or trauma EPA or the small bowel obstruction, which really are about evaluation and management, not just the operative phase of care. And there's no EPA or phase that has 0 assessments. Severe pancreatitis has the fewest number of assessments, which tells me that, or at least one interpretation, is that patients with severe pancreatitis are less frequently managed by general surgeons when you look across the country in terms of who is caring for those patients. This is another thing that I think that we have learned that we need to pay attention to. All of you are high performers. And when you are assessed, you want to be assessed at a high level. As faculty, we appreciate all of the hard work that you do, and we want to give you positive reinforcement. And we've been taught that you give feedback in sort of a feedback sandwich, which may or may not be the current model that is most appropriate, but that's what we learned. So when you work hard, we want to give you positive reinforcement. And we think that when we give you positive reinforcement, that will reinforce your want to work harder. And of course, you want to be marked superior. However, if the hard work that you put in really isn't meeting the mark and isn't displaying the behaviors that we need to see in order for you to safely care for my patient, our patient, your patient, this psychology can be harmful, and it can be harmful to patients. So where we need to get to is on the faculty side, yeah, he's nice and he works hard, but it might hurt my patients if I mark him practice ready. And as faculty, it is our responsibility, at least that's my belief, that we need to lead this change in how we use formative assessments, one assessment on one day in the midst of an entire training paradigm. And then ultimately, that will change so that the resident wants to hear what they need to do to be practice ready, rather than just wanting to hear that they are a superior trainee. So let's take a look at the near future, how formative assessment might work. So we've identified from a faculty or a program perspective that there is a resident that needs a little bit more help in order to meet benchmarks. So the milestone patient care might need to be addressed, rather than saying, yeah, you need to read a little bit more. Yeah, go to the skills lab. Somebody will meet you in the skills lab if they have some time. We can say, well, the plan is going to be, you as a resident need to initiate 10 EPAs per week, and you need to request the faculty that you are working with complete 10 EPAs per week. We're going to meet in 2 weeks to review that, with the expectation that you will have had an entrustment rating or an entrustment level of direct supervision at that 2-week mark, having been at the limited participation, and that every 2 weeks subsequent, we will look at the feedback and make a shared decision about what the expectations are going to be moving forward. Now let's take a look at how EPAs can work in a summative perspective. This is a CCC discussion in December, taking some of your SSAT leadership. And you have a PGY5 resident that the CCC is discussing. And all EPAs have had assessments, and they have all been at the indirect supervision or practice ready level. Well, this is a pretty quick CCC discussion. You can give that resident post-CCC feedback that they're very much on track and just need to focus on those few phases and few EPAs in which they are indirect supervision in hopes to be practice ready by the end of the year. Then you have a PGY3 resident, and there are 5 EPAs with no assessments whatsoever. Now, there's many different interpretations there. It might be that that resident has not been on rotations and has not had exposure to those clinical areas. As a program director or program leadership needs to look at the resident's schedule and adjust it so they have opportunities for the resident to get feedback and then opportunities for the program to make summative decisions. It may be that the resident knows they're a little deficient in those areas and is shying away from those encounters. Different discussion. And then you have a PGY2 resident who has limited participation in 8 EPAs. That resident is in trouble and needs a very quick and very formal remediation plan to be put in place. So much more information than we have ever had about resident performance. So what is the future, the further future hold? Well, there is the opportunity to do a lot of research, and Dr. Lindemann showed some of the research that came out of the pilot. I think it is important to understand that this is not being done as a research as an academic exercise. This is research that is using the information to try to change the paradigm, and that distinction may be subtle, but I think it is a distinction with an actual difference. We have a research committee that looks at research proposals related to EPAs, and there's a form available on the ABS website for research that anyone might want to do, and a consortium being put together to look at what might be able to be done in a prospective manner, knowing that all of the data that are being collected can be only looked at in a retrospective manner and in a de-identified manner. Currently, and for all the years leading up to 2028, there are requirements to be admissible to the certification pathways. You can see those on the left. They're likely familiar to all of you, and the signature of your program director. That's what you need in order to become a board certified surgeon, or to become admissible to the pathway to become a board certified surgeon. And at the end of the day, what EPAs are really trying to do is to provide much more information that underlies that program director's signature. And one of the things that might do is say that you have 47 weeks or 44 weeks or 45 weeks, but you can show us that you are practice ready in all of the EPAs. That is much more, that has much more weight and is much more justifiable from a serving the public perspective than just my signature as a program director saying, I think this person is ready. That uses the language that all of us have agreed that is or to assessing whether whether competence has actually been achieved. So what that looks like in the future, I'll refer everybody to the blue ribbon panel that was recently put together that suggests that when and if we are able to use competency-based assessments in a data-driven way, that reduction of the overall time in training for general surgery is a goal. So again, the reason, the why, is the serving the public. And we do that through rigorous evaluation and assessment. And EPAs are really the core, the new core of that rigorous evaluation and assessment. I look forward to questions and hope that you have seen that we have successfully deployed. We are getting more and better information. We have a near future that's attainable, and this is still very much a work in progress. Thank you very much.
Thank you so much, Dr. Brazel. Once again, please put your questions in the chat and we'll address them all at the end. We'll keep moving along. Next up, we have Dr. Bridget Fahey. Dr. Fahey is a professor of surgery at the University of New Mexico. She's the chief of the Division of Surgical Oncology and program director for the CGSO Fellowship. She is double boarded in surgical oncology and palliative care and an expert on the delivery of culturally sensitive palliative care. She serves as an ABS counselor and co-lead on the CGSO EPA writing group. Thank you so much, Dr. Fahey, for coming to talk to us today.
Well, thank you, and I'll just echo my esteemed co-panelists for the gratitude to the SSAT and to you, Dr. Chittani, to allow us to talk about this. And I think as the fellowship director and representing the CGSO board, we are going to launch soon. And so I appreciate the platform to kind of spread the gospel to the surgeon community and hopefully some future surgeon fellows on the call. So we can go to the next slide, Bev. So this is the structure of our process, and it's been alluded to a little bit through Dr. Lindemann's talk, but I really can't have this discussion at all without acknowledging Larry Kim, who is an endocrine surgeon at the University of North Carolina and who chairs the CGSO EPA committee. I think I was invited to speak because I actually touch the abdomen and the alimentary tract, and he does not, except for the adrenal gland, to like push the chitlins out of the way. So I think that's how my invite came. So this really is a marriage in terms of our own specialty between the CGSO board and the American Board of Surgery, who has had unparalleled leadership in this area. The next kind of major player then is the CGSO Scope Council and then the CGSO Writing Group, and we can go to the next slide. And what you see is this kind of iterative process. I've listed the members of the Scope Council, partly because they have done a bunch of work, and also because I think we tried really hard to get some representation from program directors, different practice settings, different tumor focuses to kind of come in and inform what the actual EPA selection was going to be for CGSO. And then Dr. Kim, again, really hats off to him, put together these really great dyads and triads of people who actually did the writing. For those of you that may have been on writing groups or have done that, thank you, Dr. Chittani, for many hours with me in various hotel rooms, writing up these EPAs. And there's too many people to thank in those writing groups. But I think what's been important is, sure, you have, esteemed colleagues like Dr. Lindemann and Dr. Brazel, who've been advisors. But we've also had general surgery residents, surgeon fellows to help inform this, because I think we want them to be credible, which is only going to help increase the uptake and the buy-in to this whole process of this shift in competency-based assessment. You can go to the next slide. So the EPAs were chosen, as you were hearing before, but kind of specifically, these were meant to be activities that all graduating surgeon fellows are expected to be able to do independently by the end of their fellowship. And so taken together, they really are meant to define the core elements of what complex general surgical oncology is. but they are not meant to be the entirety of the specialty. They're not a curriculum. And if you look at that suite of general surgery EPAs, there's lots of things that general surgeons are doing throughout their day that are not necessarily captured. But what this says is this is what we as both trainees and as surgical educators believe are the core parts of our specialty. All of our fellows must be accessible on all of the activities, and I'll talk about kind of how we pick them and what data was used to inform that. So these are meant to be within the field of complex general surgical oncology, common diagnoses that occur frequently. And I think Dr. Brazel mentioned, severe pancreatitis is not something maybe every general surgery resident is seeing, and that's important data. Or, maybe we're just not doing a good job of capturing assessments in that area. And then finally, this is the EPAs are meant to reflect the management of the entirety of the disease process. And one of the things I think I'm going to highlight over the next few minutes is what's the difference between the general surgery EPAs and what it looks like to do this at the fellowship level, and particularly in a fellowship like surgical oncology, where yes, the operation is important and we like to do cool surgeries and take out 25-pound sarcomas and stuff, but it's really about, did the right patient get the right treatment that got to the operating room? And then how did you follow it afterward? So I think that pre and post-operative care just as important as the intraoperative care. Next slide. So this really busy blueprint is meant to show you just a snapshot of what the Surgical Oncology Board has put together to say, what are the things that we need to assess our fellows on? And you can see over at the top, it's what kind of imaging goes with working up a hepatocellular cancer, and what's the intraoperative management for an IPMN, and what is the surveillance that needs to happen for a pancreas adenocarcinoma. So again, this is giving you just a little window into kind of the full spectrum of just a couple of diseases within our specialty. Next slide. And then we were able to leverage data that the board was able to provide about what cases are graduating complex general surgical oncology fellows doing in their 2-year fellowship. And this is from 2022. And what I have here with the red arrows is showing you kind of the highest number of median cases. So much to Dr. Kim's chagrin, the adrenal gland did not make the cut, even though that he thinks it's at least the third most important organ in the body, because the average or the median number of adrenals that a surgeon fellow does is just not high enough to make it sort of make that mark, if you will, of having enough reps, if you will, to be an accessible thing. You can see we don't do a lot of esophagectomies on a median level. And so we combine that. And so you'll see that ends up being 1 EPA, because we wanted to be able to assess a fellow who was doing esophagectomies, but there wasn't enough to build an EPA all just around esophagus itself. And then one more, I think, Bev, one more click. There you go. And so you can see parathyroid and thyroid there. So again, that was another one where we combined those 2 tumor types together under 1 EPA. Next slide. Oh, sorry. And then there are a couple of areas that we also thought were really core to our specialty. That included peritoneal surface malignancies. And anybody who knows me knows that you're not going to get away without saying palliative care within the 15-minute talk. So, and yes, there is a palliative care EPA, because we really felt like this was also core to our specialty. Next slide. So here's the 12 EPA suite for complex general surgical oncology. I won't read them to you, but again, these were chosen specifically based on the fact that they were considered to be core to complex general surgical oncology, frequent enough that every complex general surgical oncology fellow is going to see these in all of the different domains, pre, intra, and post-op, to have a meaningful number of assessments to be able to assess that fellow and figure out whether or not they're going to be practice ready by the end of their 2 years. Next slide. So I would never submit that either Dr. Lindemann is the one who created the wheel on the right, or that I am the bearded guy on the left. But the idea was we were really fortunate in complex general surgical oncology to not have to reinvent the wheel. That there were so a lot of lessons that were learned. I won't say there were any mistakes, but there were some rich learning opportunities through the general surgery process that we were able to incorporate on the surgeonic side so that we got to make new mistakes, if you will, as we were going through the process. Next slide. So you saw that the suite of 18 EPAs for general surgery, and you can see I kind of highlighted those that we were then able to leverage, but they're not the same. So the idea is this is not just we took the breast disease out of general surgery and we plopped it into surgeonic and we called it good and just went to the bar. We had that, but they did form a platform for us to kind of start to know what's a general surgeon going to come out of being practice ready. And then how is a surgical oncology fellow going to start off from that foundation and continue to build? Next slide. So you can see I'm just highlighting colon disease here. So general surgery, it's evaluation and management of a patient with benign or malignant colon disease. Of course, in surgeonic, we got rid of the benign stuff. And the description is that kind of that laundry list, if you will, of all of the things that fall in and around colon cancer, between malignant polyps, hereditary colon cancer syndromes, and so forth. And then importantly, how do we do surveillance and work in a multidisciplinary fashion? Not that general surgeons never do that, but that really being a major part of the identity of a surgical oncologist is that multi and interdisciplinary care. Next slide. So now I'm giving you a snapshot again from the scope, kind of what are the things that are accessible within the general surgery EPA for benign and malignant colon disease. And you can see that it's colitis. It does include colon malignancies, you can see, for general surgery. And then if you go down and you look under the EPA for colon cancer for surgical oncology, of course, it's the benign or the malignant polyp, and colon cancer. You see some real specifics about the oncologic types of resections that we are going to be assessing our fellows on, primarily focusing on the adult population. And then again, when you look at those out of scope, we're not including things like benign conditions. And you may say, well, what about gastrointestinal stromal tumors? How can those be out of scope? Well, those go into this other lovely category of other GI because we didn't have a good name for it to incorporate those other types of tumors. Next slide. So, and then I, again, just gave you a little bit of a snapshot of kind of what this looks like at the indirect supervision level. And you've heard about the 4 levels of entrustment from primarily observing through practice ready. And you can see that we've then taken kind of what are the behaviors, what is it that is actually going to be on that simple app, that assessment that the faculty is going to look at to say, okay, is the fellow able to understand tumor biology? Are they looking at genetic mutations and so forth under the pre-op phase to know what, and how does that then inform the extent of resection that the patient's going to need? Are they thinking about the fact that the tumor's growing into the bladder and we need to get the urologist involved pre-op, intraoperatively or consulting them pre-operatively? And then again, post-operatively thinking about that management. So I think what you're seeing here again is that we took kind of some of the foundation of general surgery, but really built on it to the parts that are most relevant to a surgical oncologist. I'm assuming my fellow can do a right hemicolectomy when they get to me because they come from good programs. But what I need to know, Erin, is what are you going to do with the trickier situation, that partially resected colon polyp that wasn't tattooed, that was in a patient that has this family history of polyposis? Now what are you going to do? Go to the next slide. And so you've heard about or you've seen the simple app. Hopefully many of you are using it already. I can tell you I have one I'm about to fill out for intraoperative for melanoma here. I'm one of my residents here shortly. So again, I think really hats off to the American Board of Surgery for going all in on really trying to support programs to be able to use these assessments and make it user-friendly as it can be. Again, so the app is free of charge. The 4 entrustment levels that you've heard about, the 3 phases of care, pre, intra, and post-op, and then anchoring those to specific behaviors. Again, these are everyday physician activities, as Dr. Lindeman mentioned. This is, did you have the patient in lithotomy for rectal cancer? Did you have an intraoperative ultrasound ready for the liver resection? Things like that. And I think the power really is in the narrative feedback, that ability. And I can tell you it's pretty easy to just push the button and say, the trainee was able to look at massive mystery, as I call them, which is like a lot of my practices, and sort of think about a wide differential understanding, patient needed a biopsy beforehand or not. And then as you were hearing more in Dr. Rouse's talk kind of about some of the analytics and some of the data that we're going to get at the board level, but most importantly, as Dr. Lindeman mentioned, in the CCCs, so that we're able to really assess, is this trainee ready? Where do we need to make up some ground? Next slide. So the key to success is, next slide, is this feedback loop. And if you press one more time for me, Bev. And I know that I was actually surprised to learn that half of the assessments are initiated by faculty and half by the trainee. I would say really that in our shop, the onus is really on the trainee to start this. And I think you really, the trainees want to get a lot out of their experience. They've invested a lot to get there and they want the most out of it. So I think, faculty want to give that feedback. They get busy, but I think there's nothing like getting pinged to say, hey, you've got an assessment to do. I never get mad. I'm actually sort of grateful that somebody reminded me that that was one thing to do. And they're very quick to complete, but it can be so powerful. And I think one of the other major differences is, we don't have 5 years in surgical oncology to get this right. And so I think that's why really the onus being on the fellow to initiate those assessments as often and as frequently as they can, because you're not probably going to go on to the HPV rotation, maybe you will, every single month. And if you're on the breast rotation, you got to really carpe diem and make use of that time to get those assessments done. And that's been sort of the stick that I've been trying to say to my residents. That's fine. We're good. And then this is sort of the timeline. So here we are in December, and that we're in the ... phase of that second line, where we have completed all of the writing. It's now off with the medical editor to clean up grammar and some other shenanigans to make it look pretty for us. And then we launch with the start of our next academic year. So I am incredibly grateful for the opportunity to get to talk about the Surg-Onc EPAs and hopefully shed a little light about what this is going to look like in a more compressed manner. And I'm really grateful to the work that's been done by my esteemed colleagues on the call too, to start to get the word out. So my job's way easier because I don't have to explain what an EPA is, thankfully. So thank you again so much for the privilege.
Thank you so much, Dr. Fahey. A quick plug, as someone who, as a trainee, was involved in generating these EPAs, it is a phenomenal opportunity to really take the reins of your own training and invest and buy into this process. We, of course, need all the help and encourage you to be as active in that process as possible. We'll move right along. Please drop your questions into the chat and we'll address them at the end. Moving along to Dr. Amy Holmstrom. Dr. Holmstrom is an assistant professor of surgery at Indiana University, where her practice focuses on MIS and bariatric surgery. Since her days as a resident, Dr. Holmstrom's research focus has been on surgical education, particularly the development of autonomy and tools for assessment. Not only has she been instrumental in the development of general surgery EPAs, but she is a thought leader on implementation and feasibility, which is what she is here to talk to us about today. Thank you so much, Dr. Holmstrom. Please take it away.
Thank you so much for the introduction. And I can also put a plug in because, as he mentioned, let's see, there we go. My only disclosure is actually that the only reason I was invited is because I've been involved as a volunteer since I was a trainee. So that's actually how I've been able to give talks on these webinars and actually at meetings and be involved with people as esteemed as my panelists, because I really just got involved as a trainee and I even helped write one of the general surgery EPAs. So do take that opportunity. It's been amazing for me, and I'm loving it. Continuing to be invited on panelists like this. So I want to talk to you all about some hurdles with implementation. And I think we have to be honest and level set here. There are a lot of people who still don't even know what EPAs are. And thank you, Dr. Lindeman, for telling everyone it's not the Environmental Protection Agency. Don't worry. I know plenty of my colleagues, even at my institution, still don't really fully understand what they are. And I think we have to recognize that a lot of our implementation difficulties for gathering this data is because people still don't know what they are, how to complete them. So I'm going to go through some resources on how to help at your institution. And then we'll talk about getting that buy-in, getting more people engaged, which starts, of course, with teaching them how to do it, and then getting some culture teams going. So I want to begin by just putting a plug in for champions. Maybe you already have some at your program, or you just have some really great educators who you can keep in your mind when thinking about who to choose for champions. I'm going to call them out as how they can help throughout this process, so keep that in mind. So starting with what they are, I'm not going to talk about what they are. I'm just going to talk about how to educate your faculty, and hopefully your trainees already know what they are, but them as well. This is a screenshot actually from a video I'm going to show you how to get to, created by Dr. Erin White as she was finishing up her general surgery residency at Yale. It is excellent. It's less than 5 minutes. Go to the American Board of Surgery website. There is an entire drop-down menu for EPAs, and there's an entire page dedicated to resources. So again, not reinventing the wheel here. Use the resources that have been created. They're excellent. When you go to that page, scroll down and find the resources for trainees, and you'll find a trainee toolkit. Click on that, and I'll bring you this beautiful page and a beautiful welcome from Dr. Brazel. And scroll down and you'll find 5 resources. The video I wanted to bring you to is that first one. These resources were actually sent to every general surgery trainee as they join residency. So hopefully all of your trainees have seen them. And if you are trainees on the call, hopefully you've seen these. I think they're great for faculty too, especially this first video. It's less than 5 minutes. So here's a little snippet from it. I may not play the whole thing for the sake of time. Activities the essential goal of achieving assessment level is ready. After observing the trainee perform EPA, the attending and the trainee needs to use multiple actions to follow the person space. The app provides helpful description of what different assessment levels might look like for each EPA. And I'll move on from there. So you can see it's excellent. Again, less than 5 minutes. Different ways to get the information out as far as what EPAs are and what this whole initiative is. Grand rounds are always great, but remember it's just 1 hour. You can always ask for an in-person speaker or that's actually recorded. Dr. Lindemann gave an excellent entire grand rounds talk that's recorded, and you can play that. But people tune out, people miss grand rounds, so don't rely on that alone. I would encourage you to think of champions again and try to meet with individuals at the division level, maybe leadership, meet with each division, and you can play this video in front of them so you know they're watching it instead of just sending it in advance. Review what they are, and take that opportunity to review how to do it. Which, again, you're not going to have people complete EPAs if they don't have the app, if they don't know how to use it. So use your champions. I would recommend either a program coordinator or a couple faculty members again, an APD maybe. Make sure that you have a point of contact for who to go to with tech trouble. When you're really working on this, I would recommend having a reminder. Almost every M&M or every grand round, you can put up these QR codes just for a minute. And then again, remind them who their point of contact is. If you're having issues, if you still don't have the app, if you still don't know how to work it, ask this person. And they can even maybe get up at the end of grand rounds or M&M and go find them, right? Hammer this home, get these people to get this going. And again, I bring you to the American Board of Surgery website, find an entire page dedicated to mobile platforms. So if people have trouble, There's a recorded video. This one is 6 minutes long, but it goes through exactly how to do it. There's also a PDF step-by-step guide, and those QR codes are at the bottom of that PDF too. So you can attach it to every weekly email that describes what the M&Ms are or the grand rounds are. Again, remind them, by the way, here's this. Resources exist, don't invent the wheel. Don't reinvent the wheel. So who should do EPA assessments? I know we already talked about this, Dr. Fahey mentioned this. I would encourage you to tell everyone that everybody should do it. Reason being, you want everyone to develop that habit. And I, guilty, EPA enthusiast, I forget to do these. And the reason is there's a bunch of things that are not, that in my scope of practice that don't have an EPA. So bariatrics, foregut, which hopefully as fellowships start doing this more and more, it will, I'll have it for all of those, for my fellows too. But since I'm doing all these surgeries where I don't have one, it's not a habit for me. And so when I do, and I don't always have a trainee as well. So when I do have a trainee and I do say a chole or a hernia, I forget, guilty. But if a trainee sends me an EPA, 100% of the time, I'm going to fill that out. So it's that Swiss cheese model. If you have the faculty, they're always doing hernias and choles and they just do it, and they always have a resident, they're doing it all the time. They're going to get EPAs to those trainees who maybe are too shy or forgetful, right? And then it goes the other way too. Those trainees are going to get me because I'm definitely going to fill it out. I just forget to do it. Guilty. So when do we do it? This is really important. I think you need to stress to do it as close to the encounter as possible, because the more time passes, the more likely it is to just not happen altogether, but you also forget things. And I really do think there's a ton of value in that narrated or dictated feedback. And you're going to forget parts of it if you don't do it soon. So if you're the trainee, I recommend doing it right after you put in admit orders for a consult you just staffed, or the post-op orders, right? Or consider using anesthesia downtime, the patient's getting intubated, activated. Or for those non-op ones, after you staffed the consult or just staffed a clinic patient or wrote those notes, that's a great time to pull out your app. For faculty members, maybe you just scrubbed out trainees closing skin, pop open your phone as you're walking to talk to patient's family and just do it then. Or it's really helpful sometimes I like to tie it to documentation. So after you finish the op note, you were just thinking about it, do it then. Or when the trainee sent you the clinic note or the consult note on a patient they staffed with you, and you're attesting it, addending it, boom, pop open the app, get it done. So we talked about some of the basics, like I said. Now let's talk a little bit more about getting that culture change, engagement, and a little bit about data use. So we talked about champions already. I want to remind people you can enlist not just faculty, but trainees as well. So depending on how big your program is, maybe 1 to 2 for the juniors, 1 to 2 for the seniors, or if you're a really big program like us, we have 10 per class, you could do 1 per class or 2 per class even. And then really important to get your leaders to buy in. We all know culture is sort of a top-down thing. If your leadership aren't really doing it and engaged, it's probably not going to happen. The EPA pilot, the most successful programs had really high level engagement. The chair in the PD, actually University of Wisconsin with Dr. Minter, who's on the call, and then Dr. Greenberg was their chair, or their PD at the time, had the best success. Again, if you have division chiefs, of course, or if there's like a faculty member who is responsible for the service, that would be a good person to choose as well to get involved. So some engagement ideas that people have done. This is from my program, IU. We had this dashboard and we sort of celebrated the first faculty member. This was a year ago now, who got to completing 100 EPAs. We celebrated some faculty and trainees who got to 20. We also showed this bar graph showing which EPAs were being used and which phases, and that can sort of highlight deficiencies. So, hey, endocrine surgeons, look, thyroid, parathyroid disease is low. Let's get going, Dr. Lindemann. Or, hey, we need to work on these other phases of care. And this is a year old, but this is great to do something like this. I do encourage you to think thoughtfully about this, though, because there has been some folks who feel a little discouraged. We'll talk about scope soon, but those endocrine surgeons just have thyroid, parathyroid in surgical consult. Acute care surgeons or MIS, we've got tons of stuff, right? So if you go by pure numbers, some people are going to feel like, why should I participate? I'm gonna lose. I'm never going to get the numbers. So think about doing it by percent completed, perhaps, or maybe do by leaderboards by folks who have more, like a smaller number of scope compared to other people, right? Do this however you want. Will work with your program, whether it's emails, you can share it at weekly M&Ms or at major grand rounds, whatever you think will work for you. And then I hinted at this already, defining scope can be really helpful. So we'll talk about this. You've seen this picture already. This is the general surgery EPAs. There's 18 of them. And this is something I stole from Dr. Linneman. I think this is from her program, but think about the different services you have and then map out which EPAs you want to assign to that. And just because those surgeons do that EPA, you don't have to assign it to them. You also don't want to overwhelm a service and make it feel like they're responsible for all the EPAs of the program, right? That's usually acute care surgery. And then make sure those champions or your division or the rotation faculty lead knows and says, you know, to the trainees and to the faculty members, these are the EPAs you need to do while on the service. So again, we talked about endocrine already because it's very simple. They've got those two. MIS, hernias, gallbladder disease, endoscopy. For colorectal, that would be bowel obstruction, colon disease, and anal rectal disease. You get the picture. Go on like that. So then again, with defining that scope, it's really helpful to engage your trainees and your faculty, especially those champions, in setting specific goals. This can really help get people going. Whether it's by individual, you can say you want 1 a day or 1 to 2 every clinic, and that can lead up to something like 20 to 30 assessments per month. By division, you could say maybe every operation or every clinic you want 1 to 2 assessments. And that could be something like 60 per month. Or you could just say at the program level, hey, every trainee needs at least 10 EPAs from at least 2 different faculty every rotation. So that can be 10 per rotation. Either way, this is a lot more data than we've really ever generated. So this is great. Do something that you think will work for you and your service structure and division structure. So some incentives, that cannot help sometimes. It's really helpful to recognize top performers. Again, think about how you do that, because you don't want certain faculty members to feel discouraged because there's less EPAs that they do in their scope of practice. Some programs I've heard have given a party for the PGY class that had the most. And then again, be vocal, do it in a public setting, at graduation, recognize people, because that helps create the culture and really shows the trainees that you care and that it's important and will really make a difference. Our program's actually doing this. If you can, find a way to tie it into compensation, believe it or not. So we're doing this for our sort of academic faculty citizenship, and we're doing it by percent completion. So if you can find a way to do that, certainly money talks sometimes. And then I believe it's Dr. Linneman's program is doing increasing the professional funds for their faculty EPA champions, and you can do that for trainees too. It does come with, of course, increased responsibility. So at the faculty level, at, say every month or whatever the length of a service rotation is, they do a little biopsy. They see what EPAs were completed, what phases, are there any trainees that really have no EPAs or very few, and are there any faculty members having problems? And you can feed that data back to your program and or your those folks and try to figure out what's going on. How do we make this better? And then, of course, we talk a lot about by addition by subtraction. Let's get rid of some other work, right? We don't want to just give you more. So trainees really don't have to do clinical or operative observations anymore. EPAs cover that. And a lot of programs have gotten rid of those long end of rotation evaluations and made it just about professionalism and teamwork. Make those really short. And so I'm going to, for the sake of time, skip some of this because Dr. Linneman went through it, but I really think it's important to teach trainees to use this language to promote autonomy conversations. So there's actually a whole video on that trainee toolkit of me doing a whole bunch of these. But again, teach your trainees to use this language and ask to do autonomy based on their data that they've been doing. So tell them to use it. And that helps engage faculty members. Maybe all of a sudden all these trainees are having these conversations with them and they'll start learning the language whether they want to or not. A couple practical challenges, and like outside rotators not being in the system, we can get those people added. Maybe some services where junior residents are staffing most of the fellows or senior residents. I certainly think it's probably within scope to consider letting fellows do those. I know right now senior residents are not, so we need to think about that. If you are having unique challenges, certainly let the American Board of Surgery know it's possible. Other programs have already found a solution to a similar challenge, or maybe there's similar challenges folks are having and we need to come up with a solution, so let them know. So in summary, don't forget the basics, teach people what they are and how to do them, and there's tons of resources on the website. Use your champion, define the scope, find some incentives if you can, and empower trainees to use their own data, okay? Looking forward to questions. Thanks for having me.
Thank you so much, Dr. Holmstrom. Just another plug to put your questions in the chat. We are coming up on getting close to the end of our session here, and we'll be able to address those after our final speaker. So last but certainly not least, Dr. Rebecca Minter. Dr. Minter is the professor of surgery at the University of Wisconsin. She is the A.R. Cureri Distinguished Chair of the Department of Surgery. She is a past president of the HPBA, the Fellowship Council, and the Society of University Surgeons. She is the current vice chair of the ABS Board of Directors and has served as a member on both the General Surgery EPA Advisory Council and the Writing Group. And so without further ado, very excited to have Dr. Minter talking to us today about progressive autonomy in the operating room and how EPAs have changed the game.
Okay, I can't see anything's gone away, so I'm going to try to share again. How many times we've done this in the last 4 years? I'm going to move quickly. Are you able to see the slides? It keeps changing my screen for some reason. Is it in?
Now.
It's not a presenter view, but we see them.
Some presenter view here.
There you go.
Okay, perfect. Sorry, it keeps changing my screen. Apologies. I'm going to move quickly because I have some also overlapping things from some of our prior speakers. But I was asked to speak about how do we really use these data to inform that higher level decision making. And I'm going to build on with some real examples, some of the things that Dr. Lindeman in particular highlighted, but we've also heard from many of our other speakers. My disclosures are that I am a board director for the American Board of Surgery, and really proud of the work that the board has done. But I will be sharing some specific examples from an app that we actually developed during the pilot, though the simple app has the same functionality as you've seen some similar reporting features. But if it looks a little bit different, that's why we use just a different platform. And so I don't know if this was emphasized at the very beginning before I joined, but I think this is something that frequently comes up for folks is, the EPAs aren't everything that we're going to learn in general surgery. And I think that's really important to call out and recognize that the EPAs are meant to really represent the core of our profession, the core of what we have the opportunity to observe multiple times in practice, as Dr. Fahey highlighted and Dr. Lindeman. This is workplace-based assessment. But it does not mean it's everything a trainee is going to learn during the residency or fellowship. And ultimately, it's the CCC's job to bring all of these data together. The EPAs are going to be a big piece of the data and provide so much more data than we've ever had before to make these higher stakes assessment decisions. But it doesn't mean there aren't other data points that we're going to consider, other evaluation assessment that we're going to consider. And that integration of all of those data come together in the CCC. So I just want to mention that because I think sometimes people can get stuck about, well, what about this and what about that? Doesn't mean those things aren't important. It just means that EPAs maybe aren't the right assessment tool for those other things. So within that EPA assessment framework, I think we've talked a lot about the micro assessments, which we capture in the moment, a single assessment that's meant to be a resident evaluated in multiple time points in multiple conditions from multiple assessors. It's that decision that we already did all of the time. You get called in the middle of the night, the resident presents the patient to you, you make a decision half asleep, do I trust this resident? Did they give me a good story the last time? Does what they're saying make sense with the data they're telling me? And you either accept what they tell you, you accept it with a friendly amendment, or you say, I'm getting out of bed, I'll be right there, right? Like you make these ad hoc entrustment decisions all the time. And what the EPA microassessment does with that shared mental model is just try to put some structure around those ad hoc entrustment decisions we make all the time. And so Tenkati, who really the godfather of EPAs, talked about these two types of entrustment decisions. The ad hoc entrustment decisions, or then the roll up of all of that microassessment data to make these higher level summative entrustment decisions. And in the Netherlands, where Tenkati's from, this has really become the assessment framework from UME medical school all the way through CME. And they have something called the STAR system, where they actually award a higher level of responsibility that's actually recognized in their system of progressing people, of having that autonomy in a really meaningful way. And so that's how we've tried to think about this in our own structures in the United States. But to achieve that vision of using all of that microassessment data to make those higher level assessment decisions, it's critical to really, and Dr. Holmstrom talked about this some, it's really critical to use that data in a way to leverage that decision making, as is referenced in many of the talks, and to make it really visible. And I think Dr. Lindemann talked about the ether. I talk about the black hole. I think, in the pilot, one of the challenges was we were so focused on just figuring out like how to do it, how to collect the data, that we learned a lot about how to collect that microassessment data, but we were really in our infancy in terms of what do we do with it? How do we use it in a meaningful way? And so I really think the value of EPAs and the way that we catch people and keep them coming back is going to be in how we leverage the analytics and show the value of completing those microassessments. Yes, it's nice to get that little quick hit and to get that little bit of feedback, but when you start to see the picture that they can paint over time and really help to identify people who may be struggling earlier, that's really going to be the value that creates that positive feedback loop of people continuing to engage. If, however, you ask people, you do all the incentives, and then people do the EPAs and they don't ever hear anything more about it, kind of like patient safety reporting. If you submit your HERO report and you never hear about it again, guess what? You never submit another HERO report. So it has to have perceived value. It has to come back. It can't be a black hole. And there's different stakeholders, and they care differently about different pieces of data. And so we've really tried to think of it through that lens of the different stakeholder groups. And today I'm just going to talk about the Clinical Competency Committee lens, but I think it's important to remember that each of these stakeholders has different data needs. The program administration has to submit to WebAds the milestone report and prepare for the CCC, and they need that to be really straightforward and easy. The residents have a certain set of needs, the faculty, and the Clinical Competency Committee has to be the one that puts all of this data together. So what does that look like? So this is our CCC workflow, just to contextualize kind of when we talk about what does this actually look like. So the steps that we follow is it's ready, time for the CCC, program coordinator pulls up our dashboard and generates summary reports to start. And so we have a couple of people who will review each resident. They'll be given the summary EPA reports, as well as the milestone reports, and they'll get the summary qualitative feedback, all the comments, as well as some other visual metrics I'll show you. And they review all that data and come prepared to discuss and present. So then during a CCC meeting, the training summary gets pulled up, which I'll show you for each resident on our EPA Analytics dashboard for discussion. It has some really nice visuals, as well as the ability to drill down on more specific data. And we also look at the milestone estimates. Again, we have to submit those milestones. And one of the beauty of EPAs is our faculty no longer need to even know what the milestones are or what the competencies are, but they're under the hood, right? They're still under there, and we'll be able to pull that out based on our EPA data at the CCC. And we make this determination about how residents are progressing. The associate program director then incorporates all that feedback, confirms the milestone projections based on the feedback, and finalizes that. And then that goes back to the resident for their meeting with their mentor every 6 months. So that's our process. So what does it actually look like? So here's the first EPA summary. So this is an example, and I want to just call out a couple things here, and Dr. Lindeman shared a similar table. Immediately you can look and decide what's my confidence in this. So if we take gallbladder disease, 23 microassessments from 17 different faculty, we're going to have a pretty high level of confidence in that one. This one, post-op appendicitis, one assessment, one faculty, we're probably not going to have a high degree of confidence. We're going to say we need more data points before we're going to say they're practice ready on that. I wanted to emphasize this down here. So back to what we heard from several speakers about the need to automate this behavior. We have a generic microassessment. It's not an EPA because by its nature, it can't have those defined behaviors. But to automate the behavior of getting feedback every single time you have an interaction, we wanted to have the ability of the resident to seek feedback. And you can see this resident did that a lot. They have 53 generic microassessments that they have sought from 22 different faculty. That helps with the forgetting piece, because if you have the ability to fill it out every single time, no matter what, and we use the EPAs, and you can favorite your EPAs in the app so that it's easy to get to. I only have 5 because I have a very narrow practice. It's easy for me to do that. So even if it's a one-off, it doesn't have an EPA, I can either use the fellow level EPA for pancreas or the generic one as a pancreas surgeon. So that's just another thing that's been helpful to us in terms of automating that behavior. This is a visual that we can start with, looking at the overarching big picture. This was taken earlier in the pilot, but we now have this populated with all 18 EPAs. You can see the 3 phases of care. So this is inguinal hernia, appendicitis. As has been noted, we get a lot more data on the intraoperative. We're working, as Dr. Holmstrom mentioned, on driving those pre, post, and non-operative phases of care. And for us, the red dots are the faculty assessments, the blue are the resident self-assessment. So our app requires dual assessment in both directions. The resident has to self-assess before they can see the faculty assessment. And the faculty cannot see the resident self-assessment before they complete theirs, but it's very informative. Every time I get an EPA from the residents, I found my assessment and then I immediately go see what they said, because it gives you a lot of insight as to how much insight they have in terms of their level. And we talked about some of the gender data, but I'll show you a nice example of that. But it also helps us if we see someone who's a consistent under-assessor of their abilities. It helps me tailor how I give my feedback to them, because they actually need to be more confident in their abilities. And to be totally fair to our male colleagues, the data that Dr. Lindeman presented, we have repeated now with thousands of assessments, showed the same thing. Our female trainees at every single PGY level, even more strongly, assess themselves compared to faculty. Our male residents do not overassess. They're just much more accurate. They assess at the same as the faculty. So it's very much a enculturated bias that we all have. And when you put the faculty assessment of female and male on top of each other, again, no significant difference for the faculty assessment. It's really a self-assessment phenomenon where we see the female trainees under assessing. And so here's a great example. Then we can hover and we can say, hey, this person, is this like, a hawk assessor, or was this a hard case? And you can hover on that dot, in the CCC, everybody knows the hawks and doves. So you can hover over that and see more information about that, and it'll pop up who it was, as well as their comments on the case. So again, nice visual picture. This is an example where we have kind of the overall big picture on a single EPA. So now if we wanted to just look at gallbladder disease, and again, faculty assessments in red and resident assessments in blue. And here we can see there's pretty good alignment. Sometimes what we'll see in a trainee is significant underassessment. You'll see very instantly all the blue dots are below the red dots. And it just becomes immediately clear on this graph. And again, we tend to see that more commonly with our female trainees, but it gives you a sense of how consistent the assessments are between faculty and residents. And here they're pretty consistent. You can again see all of the comments. They'll continue down below here, and it will show you over here the entrustment levels, the confidence intervals, the counts, et cetera. So it's everything all in one location, and so we can consecutively drill down in the CCC as it's needed. here's a great example. This is a female trainee. You can see all the blue dots are down here, all the red dots are up here. So part of the feedback from this CCC was around the fact that they are consistently underestimating their abilities as compared to their faculty assessments. Like everyone else, we see about a 50-50 split in terms of who initiates the assessment, faculty versus resident. But again, you can just see the robustness of the analytics and how they can be used. This, however, I think is for the resident most valuable, but also for the assessor. So if you wanted to quickly look at all their qualitative feedback and pull out some themes to be able to give them, that's not keep up the good work, good hands, etc., you can see that we're getting much richer feedback than we historically have gotten. Here's when this resident was a PGY3, appendicitis, intraoperative. You can see talked about difficulties with entry into the abdomen here, gave feedback on what they did specifically well in terms of managing some bleeding, and then gave specific advice on utilization of the Carter-Thompson device. So there's Dr. Brazel's sandwich, except that this sandwich is bad, good, bad. It's in a reverse sandwich. But you get the idea. And then there's two other examples here. One of the things we're really working on with our faculty and resident development is how do you get to the next level? Here's what we saw. Here's how it anchors to the described behaviors. What would you do next time to get to that next level of entrustment? And so we've been working on that. And there's, for the sake of time, won't go through these other examples, but you can see the degree of the level of feedback is, again, much more focused, much more specific, and does start to give them some guidance on what to focus on next time to get to that next level. That milestone report critical, and again, this is our starting point. So just like the summary report for the EPAs, we get the summary report for the milestones. So here's the milestone. It lists the EPAs that are drawing these milestones. These are the EPAs where these milestones are mapped. And it gives the milestone level, and again, similarly, how many assessments, how many faculties. So again, here, like for PC3, mapped to more EPAs, 55 assessments, 23 faculty. You're going to feel pretty good about that assessment. Some of these down here, SBP3, PC4, where we have fewer, or PC4, I should say, where we have fewer assessments, you might say we don't have enough data, or you'll look at some of those other data points that the CCC is examining to decide how you want to augment that. So this just shows, again, this was our data from last year. So now with all 18 EPAs, and again, you can see there's really nice, very similar split, 1,900 faculty assessments, 1,700 trainees. It's really that 50-50 and really good. We have a lot of appendicitis and gallbladder disease in Wisconsin, as you can see, a lot of beer and brats. I was shocked to see how much appendicitis we had, frankly, and this is just the ones that got assessed. So, but you can see, again, as Dr. Brazel said, here's little pancreatitis, but everything else is getting assessed, which again represents that this is a pretty good representation of the core of what we're seeing in workplace-based assessment, and it can be assessed multiple times and by multiple assessors in multiple locations. So in summary, I think just to highlight a few things, I think, we think about EPAs as the activity and the behaviors, but we must operationalize it into an analytic system that really drives behaviors and shows the value. It's really critical. It's much more relatable with faculty. Our faculty are so much happier, as are our residents, with this than the end of rotation evaluation. We just had a meeting recently this week of saying, can we please just get rid of the end of rotation evaluation altogether? It may still serve a purpose, but it needs to be really scaled down to really look at global constructs that we can't assess in other ways. And I think, really engaging the residents and using their data, as Dr. Holmstrom said, so that they can say, here are the themes in my data. Here's what I'd like to work on, and say, look here in the app. Here's where I am. I'm at, practice ready from 30 of your peers. That can be really compelling. So they have access to their own dashboard. They can see all of this data. And the goal, of course, especially as we have bigger and bigger faculty and we have less and less contact with the residents, is to be able to try to use this data as a proxy for their experience rather than the let me show you how I do it 10 times, because you're not going to have that opportunity. The residents get stuck with 20 different faculty saying, let me show you how I do it. And don't move along. And it's just a reality of our current practice of having huge faculty and the residents not getting to work with the same people over and over as much. So I think the analytics are critical to driving this, and the CCC is really, the body by which this happens. So thank you, and hopefully I know we're at time, but if there's any questions, happy to participate in the questions.
Thank you so much, Dr. Minter. We do have two questions in the chat, and they both encircle the topic of next steps. I want to highlight the second question that asks, is there a plan to follow up in 3 to 5 years to check for the accuracy of this assessment program? Dr. Lindeman put forward a very thoughtful response in the chat. I want to pass the mic to her first to expand on that, and then, of course, anyone can jump in after that.
Oh, okay. Thank you very much, Dr. Chitani. You can see that I said my response was too long, so you don't have to read all of it. But really, we have endeavored to be thoughtful about this. It's an entirely new paradigm. And so the board, I think, in the same vein that others have talked about, I think it was Dr. Fahey talked about, really putting resources behind this to try to make it successful. We want to make sure that this is the right thing to do. We believe that we're acting on principles that so many of us have espoused, that what we're doing currently isn't working in the way that we think that it should be, that there's a better system. We believe this to be a better system, and we want to make sure we feel confident that that is the case. And so a group of us, of which I was privileged to be a part, took place in a research retreat and defined an agenda for all of the questions that we'd like to answer. Dr. Brazel talked about the process to submit research ideas actually to the ABS to utilize those data. There's a consortium being put together. But all of those important questions we hope to answer. And it's a huge body of work. We need your help. So we want incredibly smart, engaged, innovative individuals to come join us and help prove or learn that this is the right way to do it, or that we need further iteration.
I think I'll just add, I think, as surgeons, we naturally want, what's the right answer? What's the perfect assessment tool? What's the most objective? And I think that one of the questions is we've rolled forward at our institution is it better than what we were doing before? As long as the answer to that is yes, and then we take the next step and we make it a little bit better and a little bit better, then it's better than what we were doing before. And it needs to be a continuous journey, right? Like, we have no fantasy that we got this exactly right out of the box. But as long as it's iteratively better and directionally improved, then I think we're on the right path. I think the other important thing as surgeons that I'm run into a lot, and I'm reviewing a paper right now that really some great work, tremendous work done, but I worry about its feasibility in terms of, creating multiple interoperative assessments and tools that people will have to do. I think one of the things we've really thought about is, faculty are really, really busy and have tremendous pressures. And we all care deeply about resident education, but if we create systems of assessment that are just, while they might be, quote, better or more objective, if somebody would complete 410 item checklists, yes, that might be better, but no one is going to do that. No one will even do one checklist. And so I think it is balancing, figuring out like what works in workplace-based assessment, which is what surgical residency is, and provides feedback that is granular enough that helps people know what they need to do to improve, and then they build on that. And doesn't mean we don't use checklists in the Sim Center and other places, but in the workplace, we have to be really thoughtful about that implementation piece and what is feasible and realistic.
I think both of the questions are related. There is not a single outcome that we will say, in 3 years, we will be able to look at this single outcome and say, yes, it's worked, or no, it hasn't. That really highlights what Dr. Minter had, all of the different stakeholders. From a resident perspective, if they're getting more feedback and more autonomy, it's a win. Will that be true for every resident in every program at every level? No. Quite honestly, it won't be. That's an unrealistic expectation. We already know that it is working in that space. Again, not for everybody, not at every program. So we are doing, I like Dr. Fahey's feedback loop. We're doing a PDSA loop. Who's doing it well? Who's got the analytic dashboard that makes the most sense, that is the most helpful to show the most value. So we are constantly looking at that and getting that information out in a variety of forums, papers that you'll read in journals, webinars like this, workshops at different meetings. So the answer is yes, and constantly. And will there be an aha moment that we will say, yes, this has been a success? And I actually don't see that. I see this as constant and continuous iteration. And then maybe in 5 years, we'll add something to it and we'll take a little bit of it away. But both of those questions are super important and very much related.
Lovely. Thank you so much for those responses. And thank you so much for your time, Drs. Fahey, Brazel, Holmstrom, Lindemann, and Minter. Very appreciative of your time and expertise. Very appreciative of the investment that each of you have made in trainees like myself and those on the Zoom here, as well as making yourself available as a resource to program directors and other surgical educators. Have a lovely night, and thank you everyone for attending. This will be recorded. It has been recorded and it will be posted. We'll share the link. Please distribute it, spread the word, and have a lovely holiday season.
Thank you.
Thank you, everyone.
Thank
Take
you.
care.
Good night.